Hello. Today's learning course is lecture number 2, acute bronchitis, pneumonias, etiology, pathology, symptoms and signs, diagnosis and treatment, disorders of the pleura. Acute bronchitis is inflammation of the tracheobronchial tree commonly following a URI that occurs in patients without chronic lung disorders. The cause is almost always a viral infection. The pathogen is rarely identified. The most common symptoms is cough with or without fever and possibly sputum production. Diagnosis is based on clinical findings. Treatment is supportive. Antibiotics are usually unnecessary. Prognosis is excellent. Acute bronchitis is frequently a component of upper respiratory infections caused by rhinovirus, parainfluenza, influenza A or B virus, respiratory syncytial virus, coronavirus, human metapneumovirus. Less common causes may be Mycoplasma pneumonia, Bordetella pertussis, Chlamydia pneumonia. Less than 5% of cases are caused by bacteria, sometimes in outbreaks. Acute inflammation of the tracheobronchial tree in patients with underlying chronic bronchial disorders. For example, COPD, bronchiectasis, cystic fibrosis, is considered an acute exacerbation of the disorder rather than acute bronchitis. In these patients, the etiology, treatment, and outcome differ from those of acute bronchitis. Symptoms are a non-productive or mildly productive cough accompanied or preceded by upper respiratory infection symptoms, usually by more than 5 days. Subjective dyspnea results from chest pain or tightness with breathing, not from hypoxia. Signs are often absent, but may include scattered bronchi and wheezing. Sputum may be clear, purulent, or occasionally contain blood. Sputum characteristics do not correspond with a particular etiology. Mild fever may be present, but high or prolonged fever is unusual and suggests influenza or pneumonia. On resolution, cough is the last symptom to subside and often takes 2 to 3 weeks or even longer to do so. Diagnosis is based on clinical presentation. Testing is usually unnecessary. However, patients who complain of dyspnea should have pulse oximetry to rule out hypoxemia. Chest X-ray is done if findings suggest serious illness or pneumonia. Elderly patients are the occasional exception, as they may have pneumonia without fever and auscultatory findings, presenting instead with altered mental status and tachypnea. Sputum stain and culture usually have no role. Nasopharyngeal samples can be tested for influenza and pertussis if these disorders are clinically suspected. Viral panel testing is not usually recommended because results do not affect treatment. Cough resolves within 2 weeks in 75% of patients. Patients with persistent cough should undergo a chest X-ray. The physician to evaluate for non-infectious causes, including postnasal drip and gastroesophageal reflux disease, can usually be made on the basis of the clinical presentation. Differentiation of covariant asthma may require pulmonary function testing. Acute bronchitis in otherwise healthy patients is a major cause of antibiotic overuse. Nearly all patients require only symptomatic treatment, such as acetaminophen and hydration. Evidence supporting efficacy of routine use of other symptomatic treatments, such as antitussives, mycolytics, and bronchodilators, is weak. Antitussives should be considered only if the cough is interfering with sleep. Patients with wheezing may benefit from an inhaled beta-2 agonist, for example, albuterol, for a few days. Broader use of beta-2 agonists is not recommended because adverse effects such as tremor, nervousness, and shaking are common. Though modest symptomatic benefits occur with antibiotics used in acute bronchitis, the self-limiting nature of acute bronchitis and the risk of adverse effects and antibiotic resistance argue against widespread antibiotic use. Oral antibiotics are typically not used except in patients with pertussis or during known outbreaks of bacterial infection. A macrolide such as azithromycin, 500 milligram for 4 days, or clarithromycin, 500 for 7 days is given. Pneumonia is an infection of the pulmonary parenchyma. Pneumonia historically was typically classified as community-acquired CAP, hospital-acquired HAP, or ventilator-associated VAP. A fourth category, healthcare-associated pneumonia, HCAP, was introduced recently. Recent studies have more closely identified patients at risk for pathogens resistant to the antibiotics usually used, have defined risk factors for infection with methicillin-resistant Staphylococcus aureus, MRSA, independent of other MDR pathogens, and have found that at least two, if not their risk factors are required before the probability of drug-resistant pathogens is sufficient to influence initial empirical broad-spectrum antibiotic therapy. Here you see risk factors for pathogens resistant for usual therapy for commonly community-acquired pneumonia. Pathophysiology. Pneumonia results from the proliferation of microbial pathogens at the alveolar level and the host response to those pathogens. Microorganisms gain access to the lower respiratory tract in several ways. The most common is by aspiration from the oropharynx. Mechanical factors are critically important in host defense. The hairs and turbinates of the nares capture larger inhaled particles before they reach the lower respiratory tract. The branching architecture of the tracheobronchial tree traps microbes on the airway lining, where mucociliary clearance and local antibacterial factors either clear or kill the potential pathogen. The gag and cough reflexes offer critical protection from aspiration. In addition, the normal flora adhering to mucosal cells of the oropharynx, whose components are remarkably constant, prevents pathogenic bacteria from binding and thereby decreases the risk of pneumonias. When mechanical factors are overcome or when microorganisms are small enough to be inhaled to the alveolar level, resident alveolar macrophages are extremely efficient at clearing and killing pathogens. Macrophages are assisted by proteins that are produced by the alveolar epithelial cells and that have intrinsic opsonizing properties of antibacterial or antiviral activity. Once engulfed by the macrophage, the pathogens, even if they are not killed, are eliminated via either the mucociliary elevator or the lymphatics and no longer represent an infectious challenge. Only when the capacity of the alveolar macrophages to ingest or kill the microorganisms is exceeded does clinical pneumonia become manifest. In that situation, the alveolar macrophages initiate the inflammatory response to bolster lower respiratory tract defense. The host inflammatory response, rather than proliferation of microorganisms, triggers the clinical syndrome of pneumonia. The release of inflammatory mediators such as interleukin first and tumor necrosis factor results in fever. Chemokines such as interleukin-8 and granulocyte colony stimulating factors stimulate the release of neutrophils and their attraction to the lung, producing both peripheral leukocytosis and increased purulent secretions. Inflammatory mediators released by macrophages and the newly recruited neutrophils created an alveolar capillary leak. Even erythrocytes can cross the alveolar capillary membrane, with consequent hemoptysis. The capillary leak results in a radiographic infiltrate, and rales detectable on auscultation and hypoxemia result from alveolar findings. Decreased compliance due to capillary leak, hypoxemia, increased respiratory drive, increased secretions, and occasionally infection-related bronchospasms all lead to dyspnea. If severe enough, the changes in lung mechanics secondary to reduction in lung volume and compliance and the intrapulmonary shunting of blood may cause respiratory failure and death. Classic pneumonia evolves through a series of pathologic changes. The initial phase is one of edema with the presence of a proteinoceous exudate and often of bacteria in the alveoli. The phase is rarely evident in clinical or autopsy specimens because of the rapid transactions to the red hepatization phase. The presence of erythrocytes in the cellular interalveolar exudative gives the second stage its name, but neutrophil influx is more important with regard to host defense. Bacteria are occasionally seen in pathologic specimens collected during this phase. In the third phase, gray hepatization, no new erythrocytes are extravasiting, and those already present have been lysed and degraded. The neutrophil is the predominant cell. Fibrin deposition is abundant, and bacteria have disappeared. This phase corresponds with successful containment of the infection and improvement in gas exchange. In the final phase, resolution, the macrophage reappears as the dominant cell type in the alveolar space, and the debris of neutrophils, bacteria, and fibrin has been cleared, as has the inflammatory response. This pattern has been described best for lobar pneumococcal pneumonia and may not apply to pneumonia of all etiologies, especially viral or pneumocystis pneumonia. In VAP, respiratory bronchiolitis may precede the development of a radiologically apparent infiltrate. Because of the microaspiration mechanism, a bronchopneumonia pattern is most common in nosocomial pneumonias, whereas a lobar pattern is more common in bacterial CAP. Despite the radiographic appearance, viral and pneumocystis pneumonias represent alveolar rather than interstitial process. This pattern has been described best for lobar pneumococcal pneumonia and may not apply to pneumonia of all etiologies, especially viral or pneumocystis pneumonia. Etiology. The extensive list of potential etiologies agents in CAP includes bacteria, fungi, viruses, and protozoa. Newly identified pathogens include metapneumoviruses, the coronaviruses responsible for severe acute respiratory syndrome, CARS, and Middle East Respiratory Syndrome, MRAS, and community-acquired stains of MRSA. Most cases of CAP, however, are caused by relatively few pathogens. You see here microbial cause of community-acquired pneumonia by site of care. CAP, etiology. Unfortunately, despite a careful history and physical examination as well as routine radiographic studies, the causative pathogen in a case of CAP is difficult to predict with any degree of certainty. In more than one half of cases, a specific etiology is never determined. Nevertheless, epidemiologic and risk factors may suggest the involvement of certain pathogens. Here we have epidemiologic factors suggesting possible causes of community-acquired pneumonia. Clinical manifestation. CAP can vary from indolent to fulminant in presentation and from mild to fatal in severity. Manifestations of progression and severity include both constitutional findings and those limited to the lung and associated structure. Clinical manifestations. The patient is frequently febrile with tachycardia or may have a history of chills and or sweats. Cough may be either non-productive or productive of mucoid, purulent, or blood-tinted sputum. Gross hemoptysis is suggestive of CA-MRSA pneumonia. Depending on severity, the patient may be able to speak in full sentences or may be very short of breath. If the pleura is involved, the patient may experience pleuritic chest pain. Up to 20% of patients may have gastrointestinal symptoms such as nausea, vomiting, and diarrhea. Other symptoms may include fatigue, headache, myalgias, and arthralgias. Clinical manifestations. Findings on physical examination vary with the degree of pulmonary consolidation and the presence or absence of a significant pleural effusion. An increased respiratory rate and use of accessory muscles of respiration are common. Palpation may reveal increased or decreased tactile fremitus, and the percussion note can vary from dull to flat, reflecting underlying consolidated lung and pleural fluid, respectively. Crackles, bronchial breath sounds, and possibly a pleural friction rub may be heard on auscultation. The clinical presentation may not be so obvious in the elderly, who may initially display new onset of worsening confusion and few other manifestations. Severely ill patients may have septic shock and evidence of organ failure. Clinical manifestation. The risk of cardiac complication secondary to enhanced inflammation and procoagulant activity is increased. These complications include myocardial infarction, congestive heart failure, and arrhythmias, particularly in the elderly. In pneumococcal CAP, the increased risk of acute coronary events may be partially driven by pneumolysis, which increases platelet activation. Diagnosis of CAP. When confronted with possible CAP, the physician must ask two questions. Is this pneumonia, and if so, what is the likely etiology? The former question is typically answered by clinical and radiographic methods, whereas the latter requires the aid of laboratory techniques. The differential diagnosis includes both infectious and non-infectious entities such as acute bronchitis, acute exacerbations of chronic bronchitis, heart failure, pulmonary embolism, hypersensitivity, pneumonias, and radiation pneumonitis. The importance of a careful history cannot be overemphasized. For example, non-cardiac disease may suggest worsening pulmonary edema, while underlying carcinoma may suggest lung injury secondary to irradiation. The main purpose of the sputum gram stain is to ensure that the sample is suitable for culture. However, gram staining may also identify certain pathogens. For example, Staphylococcus pneumonia, Staphylococcus aureus, and gram-negative bacteria by their characteristic appearance. To be adequate for culture, a sputum sample must have more than 25 neutrophils and less than 10 squamous epithelial cells per low-power file. The sensitivity and specificity of the sputum gram stain and culture are highly variable. Even in cases of proven bacteremic pneumococcal pneumonia, the yield of positive cultures from sputum samples is equal 50%. Blood cultures, the yield from blood cultures, even when samples are collected before antibiotic therapy, is disappointingly low. Only 5 to 14% of cultures of blood from patients hospitalized with CAP are positive, and the most frequently isolated pathogens is Streptococcus pneumonia. Urinary antigen test. Two commercially available tests detect pneumococcal and Legionella antigen in urine. The test of Legionella pneumophilia detects only serogroup 1, But this serogroup accounts for most community-acquired cases of Legionnaires' disease in the United States. Polymerase chain reaction, PCR. PCR tests, which amplify a microorganism's DNA or RNA, are available from a number of pathogens. PCR of nasopharyngeal swabs, for example, has become the standard for diagnosis of respiratory viral infection. In addition, PCR can detect the nucleic acid of Legionella species. In patients with pneumococcal pneumonia, an increased bacterial load documented in whole blood by PCR is associated with an increased risk of septic shock, the need for mechanical ventilation, and death. Serology. A fourfold rise in specific immunoglobulin M antibody titer between acute and convalescent phase serum samples is generally considered diagnostic of infection with the pathogen in question. In the past, serologic tests were used to help identify atypical pathogens as well as selected unusual organisms such as Coxiella burnetii. Recently, however, they have fallen out of favor because of the time required to obtain a final result for the convalescent phase sample and the difficulty of interpretation. Biomarkers. A number of substances can serve as markers of severe inflammation. The two most commonly used are C-reactive protein, CRP, and procalcitonin, PCT. Levels of these acute phase reactants increase in the presence of an inflammatory response, particularly to bacterial pathogens. CRP may be of use in the identification of worsening disease of treatment failure, and PCT may play a role of distinguishing bacterial from viral infection, determining the need for antibacterial therapy, or deciding when to discontinue treatment. Now about treatment. Certain patients can be managed at home and others clearly require treatment in the hospital, but the choice is sometimes difficult. Tools that objectively assess the risk of adverse outcomes, including severe illness and death, can minimize unnecessary hospital admissions. Although a number of prediction rules exist, the two most frequent used are the Pneumonia Severity Index, PCI, and prognostic model used to identify patients at low risk of dying, and the CARP 65 criteria, a severity of illness score. To determine the PCI points are given for 20 variables, include age, coexisting illness, and abnormal physical and laboratory findings. On this basis of the resulting score, patients are assigned to one of 5 classes with the following mortality rates. Class 1, 0.1%, Class 2, 0.6%, Class 3, 2.8%, Class 4, 8.2%, Class 5, 29.2%. Determination of the PCI is often impractical in a busy emergency department setting because of the number of variables. However, clinical trials demonstrate that routine use of the PCR results in lower administrative rates for class 1st and class 2nd patients. Patients in class 3rd could ideally be admitted to an observation until a further decision can be made. The CARP 65 criteria include 5 variables: confusion, urea more than 7 millimole liter, respiratory rate 30 per minute, blood pressure systolic equal 90 millimeter mercury or diastolic equal 60 millimeter mercury, age 65 years. Patients with a score of 0, among whom the 30-day mortality rate is 1.5%, can be treated outside the hospital. With a score of 1 or 2, the patient should be hospitalized unless the score is entirely or in part attributable to an age of 65 years. In such cases, hospitalization may not be necessary. Among patients with scores of equal 3, mortality rates are 22% overall. These patients may require ICU admission. Here you see risk factors for early deterioration in community-acquired pneumonia. Antibiotic resistance. Antimicrobial resistance is a significant problem that threatens to diminish our therapeutic armamentarium. Misuse of antibiotics results in increased antibiotic selection pressure that can affect resistance locally and globally by clonal dissemination. For CAP, the main resistance issues currently involves Streptococcus pneumoniae and CA-MRSA. Antibiotic resistance. In general, pneumococcal resistance is acquired by direct DNA incorporation and remodeling resulting from contact with closely related oral commensal bacteria, but by the process of natural transformation or by mutation of certain genes. The minimal inhibitory concentration. Cutoffs for penicillin in pneumonia are 2 mg per milliliter for susceptible, more than 2 to 4 mg for intermediate, and 8 mg per milliliter for resistant. In contrast to penicillin resistance to macrolides is increasing through several mechanisms. Target site modification caused by ribosomal methylation in 2035 RNA encoded by the ERMB gene results in high-level resistance to macrolides, lysosamides, and streptogrammin B-type antibiotics. The efflux mechanism encoded by the MEF gene is usually associated with low-level resistance. Streptococcus pneumonia. Pneumococcal resistance to fluoroquinolones, for example, for ciprofloxacin and levofloxacin, has been reported. Changes can occur in one of both target sites from mutations in the GIRA and PR genes, respectively. Isolates resistant to drugs from 3 or more antimicrobial classes with different mechanisms of action are considered MDR strains. The most important risk factor for antibiotic-resistant pneumococcal infection is use of a specific antibiotic within the previous 3 months. Therefore, a patient's history of prior antibiotics treatment is common. Macrolide-resistant pneumonia has been reported in a number of countries, including Germany, Japan, China, and France, and the United States. Mycoplasma resistance to macrolides is one of rise as a result of binding site mutation. CA-MRSA. CAP due to MRSA may be caused by the classic hospital-acquired strains or by genotypically and phenotypically distinct community-acquired strains. Methicillin resistance in Staphylococcus aureus is determined by the MACA gene, which encodes for resistance to all beta-lactam drugs. At least 5 staphylococcal chromosomal cassette MAC types have been described. The typical hospital-acquired strain usually has type 2 or 3, whereas CA-MRSA has a type 4. You see empirical antibiotic treatment of community-acquired pneumonia. Treatment. Once the etiologic agents and their susceptibilities are known, The therapy may be altered to target the specific pathogens. However, this decision is not always straightforward. If blood cultures yield Streptococcus pneumoniae sensitive to penicillin after 2 days of treatment with a macrolide plus a beta-lactam or with a fluoroquinolone alone, should therapy be switched on penicillin? No. The concern here is that the beta-lactam alone would not be effective in the potential 15% of cases with atypical co-infection. No standard approach exists. Failure to improve. Patients slow to respond to therapy should be re-evaluated at about day 3, sooner if their condition is worsening rather than simply not improving. And several possible scenarios should be considered. A number of non-infectious conditions mimic pneumonia, including pulmonary edema, pulmonary embolism, lung carcinoma, radiation and hypersensitivity pneumonitis, and connective tissue disease involving the lung. Failure to improve. If the patient truly has CAP and empirical treatment is aimed at the correct pathogen, lack of response may be explained in a number of ways. The pathogen may be resistant to the drug selected or a sequestered focus, may be blocking access of the antibiotics to the pathogen. The patient may be getting either the wrong drug or the correct drug at the wrong dose or frequency of administration. Another possibility is that CAP is the correct diagnosis, but an unsuspected pathogen is the cause. Nosocomial superinfections, both pulmonary and extrapulmonary, are other possible explanations for hospitalized patients' failure to improve or deterioration. In all cases of delayed response or worsening condition, the patient must be carefully reassessed and appropriate studies initiated, possibly including procedures such as CT or bronchoscopy. Now about the VAP, ventilator-associated pneumonia, etiology. Potential etiologic agents of VAP include both MDR and non-MDR bacterial pathogens. Most hospitals have problems with Pseudomonas aeruginosa and MRSA, but other MDR pathogens are often institution-specific. Less commonly, fungal and viral pathogens cause VAP, usually affecting severely immunocompromised patients. Rarely, community-associated viruses cause mini epidemics, usually one introduced by ill health care workers. You see microbiology cause of ventilator-associated pneumonia. Pathogenesis of ventilator-associated pneumonia. Three factors are critical in the pathogenesis of VAP. Colonization of the oropharynx with pathogenic microorganisms, aspiration of these organisms from the oropharynx into the lower respiratory tract, compromise of the normal host defense mechanism. Most risk factors and their corresponding prevention strategies pertain to one of these three factors. The most obvious risk factors is the endotracheal tube, which bypasses the normal mechanical factors preventing aspiration. The endotracheal tube and the concomitant need for suctioning can damage the tracheal mucosa, thereby facilitating tracheal colonization. In addition, pathogenic bacteria can form a glycocalyx biofilm on the tube's surface that protects them from both antibiotics and host defense. Here we have pathogenic mechanisms and corresponding prevention strategies for ventilated associated pneumonia. Also, we have preventive stages for ventilator associated pneumonia. And now clinical manifestations of ventilator-associated pneumonia. The clinical manifestations are generally the same in VAP as in all other forms of pneumonia: fever, leukocytosis, increase in respiratory secretions, and pulmonary consolidation on physical examination, along with a new or changing radiographic infiltrate. The frequency of abnormal chest radiographs before the onset of pneumonia is in intubated patients, and the limitations of portable radiographic technique make interpretation of radiographs more difficult than in patients who are not intubated. Other clinical features may include tachypnea, tachycardia, worsening oxygenation, and increased minute ventilation. Diagnosis of ventilator-associated pneumonia. No single set of criteria is a reliable diagnostic for pneumonia in a ventilated patient. Application of the clinical criteria typical for CAP consistently results in overdiagnosis of VAP, largely because of these common findings in at-risk patients. First, frequent tracheal colonization with pathogenic bacteria in patients with endotracheal tubes. Two, multiple alternative causes of radiographic infiltrates in mechanically ventilated patients. And third, the high frequency of other sources of fever in critically ill patients. The differential diagnosis of VAP includes a number of entities such as atypical new pulmonary edema, pulmonary contusion, alveolar hemorrhage, hypersensitivity pneumonitis, acute respiratory distress syndrome, and pulmonary embolism. Clinical findings is in ventilated patients with fever and/or leukocytes may have alternative causes, including antibiotic-associated diarrhea, central line-associated infection, sinusitis, urinary tract infection, pancreatitis, and lung fever. Quantitative culture approach is discrimination between colonization and true infection through determination of the bacterial burden. The more distal in the respiratory tract diagnostic sampling, the more specific the results, and therefore the lower the threshold of growth necessary to diagnose pneumonia and exclude colonization. Additional tests that may increase the diagnostic yield include Gram staining, differential cell counts, staining for intracellular organisms, and detection of local protein levels elevated in response to infection. The absence of bacteria in gram-stained endotracheal aspirates make pneumonia an unlikely cause of fever or pulmonary infiltrates. This finding, coupled with a heightened awareness of the alternative diagnosis possible in patients with suspected VAP, can prevent inappropriate overtreatment for pneumonia. Since the main benefits of bronchoscopic quantitative cultures are decreased antibiotic selection pressure, which reduces the risk of subsequent infection with MDR pathogens, and the identification of alternative sources of infection. A clinical diagnostic approach that incorporates such principles may result in similar outcomes. Treatment. The key to appropriate antibiotic management of VAP is an appreciation of the resistance patterns of the most likely pathogens in a given patient. Antibiotic resistance. Frequent use of beta-lactam drugs, especially cephalosporins, appears to be the major risk factor for the infection with MRSA and extended spectrum beta-lactamase positive strains. Pseudomonas aeruginosa has demonstrated the ability to develop resistance to all routinely used antibiotics. Unfortunately, even if initially sensitive, Pseudomonas aeruginosa isolates also have a propensity to develop resistant drug treatment. You see here empirical antibiotic treatment of hospital-acquired and ventilator-associated pneumonia. Once an etiologic diagnosis is made, broad-spectrum empirical therapy can be modified to specifically address the known pathogen. For patients with MDR risk factors, antibiotic regimens can be reduced to a single agent in most cases. Only a minority of cases require a complete course with 2 or 3 drugs. A negative tracheal aspirate culture or growth below the threshold for quantitative cultures of samples obtained before any antibiotic change strongly suggests that antibiotics should be discontinued, or that a search for an alternative diagnosis should be pursued. While significantly less well studied than VAP, HAP in non-intubated patients, both inside and outside the ICU, is similar to VAP. The main differences are the higher frequency of non-MDR pathogens and the generally better underlying host immunity in non-intubated patients. The lower frequency of MDR pathogens allows monotherapy in a larger proportion of cases of HAP than of VAP. The only pathogens that may be more common in the non-VAP population are anaerobes. Diagnosis of hospital-acquired pneumonia is even more difficult for HAP in the non-intubated patient than for VAP. Lower respiratory tract samples appropriate for culture are considerably more difficult to obtain from non-intubated patients. Many of the underlying diseases that predispose a patient to HAP are also associated with an inability to cough adequately. Since blood cultures are infrequently positive, less than 15% of cases, the majority of patients with HAP do not have culture data on which antibiotic modifications can be based. Despite these difficulties, the better host defenses in non-ICU patients result in lower mortality rates than are documented for VAP. In addition, the risk of antibiotic failure is lower in HAP. Pleural effusion. Now we have discussed the disorders of the pleura. The pleural space lies between the lung and chest wall and normally contains a very thin layer of fluid which serves as a coupling system. A pleural effusion is present when there is an excess quantity of fluid in the pleural space. Etiology. A pleural effusion may develop when there is excess pleural fluid formation from the interstitial spaces of the lung, the parietal pleura or the peritoneal cavity. There is decreased fluid removal by the lymphatics. Diagnostic approach. The first step is to determine whether the effusion is a transudate or an exudate. A transudative pleural effusion occurs when systemic factors that influence the formation and absorption of pleural fluid are altered. The leading causes of transudative pleural effusions are left ventricular failure and cirrhosis. An exudative pleural effusion occurs when local factors that influence the formation and the absorption of pleural fluid are altered. The leading cause of exudative pleural effusions are bacterial pneumonia, malignancy, viral infection, and pulmonary embolism. Here we present diagnostic algorithm of pleural effusion, where CHF is congestive heart failure, CT computed tomography, LDH, lactate dehydrogenase, PE pulmonary embolism, and PF pleural fluid. Transudative and exudative pleural effusions are distinguished by measuring the lactate dehydrogenase, LDH, and protein levels in the pleural fluid. Whereas exudative pleural effusions meet at least one of the following criteria, transudative pleural effusions meet none. First, pleural fluid protein, serum protein more than 0.5. Pleural fluid LDH, serum LDH more than 0.6. And third science is pleural fluid LDH more than 2/3 the normal upper limit for serum. In a patient who has an exudative pleural effusion, the following tests on the pleural fluid should be obtained. Description of the fluid, glucose level, differential cell count, microbiologic studies, and cytology. Effusions caused by heart failure occurs because the increased amounts of fluid in the lung interstitial spaces exist in part across the visceral pleura. This overwhelms the capacity of the lymphatics in the parietal pleura to remove fluid. Isolated right-sided pleural effusions are more common than left-sided effusions in heart failure. A diagnostic thoracentesis should be performed if the effusions are not bacterial and comparable in size, if the patient is febrile, or if the patient has pleuritic chest pain to verify that the patient has a transudative effusion. Otherwise, the patient is best treated with diuretics. If the effusion persists despite diuretic therapy, a diagnostic thoracentesis should be performed. Hepatic hydrothorax. Pleural effusions occur in 5% of patients with cirrhosis and ascites. The predominant mechanism is the direct movement of peritoneal fluid through small openings in the diaphragm into the pleural space. The effusion is usually right-sided and frequently is large enough to produce severe dyspnea. Parapneumonic effusions are associated with bacterial pneumonia, lung abscess, or bronchiectasis. NPM refers to a grossly purulent effusion. Patients with aerobic bacterial pneumonia and pleural effusion present with an acute febrile illness consisting of chest pain, sputum production, and leukocytosis. Patients with anaerobic infections present with a subacute illness with weight loss, a brisk leukocytosis, and mild anemia. The presence of free pleural fluid can be demonstrated with the lateral decubitus radiograph, CT of the chest, or ultrasonography. If the free fluid separates the lung from the chest wall by more than 10 millimeters, a therapeutic thoracentesis should be performed. Here you see pleural effusion before treatment. Note small right-sided pleural effusion on X-ray and CT right. Right pleural effusion. Note the blunting of the right costophrenic angle and obscuration of the right hemodiaphragm. Here you see left-sided pneumorhydrothorax. Small right pleural effusion with associated pleural thickening. No fluid in the major fissure, black arrow visible on the lateral film as well as the meniscus of the right pleural effusion. Parapneumonic effusion. Factors indicating the likely need for a procedure more invasive than a thoracentesis include: first, loculated pleural fluid; second, pleural fluid pH less than 7.2; third, pleural fluid glucose less than 3 and 3 millimole on liter; positive gram stain of or culture of the pleural fluid; and fifth position is the presence of gross pus in the pleural space. If the fluid cannot be completely removed with the therapeutic thoracentesis, consideration should be given to inserting a chest tube and instilling a fibrinolytic or performing thoracoscopy with the breakdown of adhesions. Decortication should be considered when the above are ineffective. Malignant pleural effusion secondary to metastatic disease are the second most common type of exudative pleural effusions. The three tumors that cause 75% of all malignant pleural effusions: lung carcinoma, breast carcinoma, and lymphoma. Most patients complain of dyspnea, which is frequently out of proportion to the size of the effusion. The pleural fluid is an exudate and its glucose level may be reduced if the tumor burden in the pleural space is high. Diagnosis is usually made via cytology of the pleural fluid. If the initial cytologic examination is negative, then thoracoscopy is the best next procedure if malignancy is strongly suspected. If the patient's lifestyle is compromised by dyspnea and if the dyspnea is relieved with a therapeutic thoracentesis, then one of the following procedures should be considered. First, insertion of a small indwelling catheter, and second, tube thoracoscopy with the installation of a sclerosing agent such as 500 milligrams of doxycycline. Mesothelioma. Malignant mesotheliomas are primarily tumors that arise from the mesothelial cells that line the pleural cavities. Most are related to asbestos exposure. Patients with mesothelioma present with chest pain and shortness of breath. The chest radiograph reveals a pleural effusion, generalized pleural thickening, and a shrunken hemithorax. Thoracoscopy or open pleural biopsy is usually necessary to establish the diagnosis. You see here malignant mesothelioma, how it looks like. The diagnosis most commonly overlooked in the differential diagnosis of a patient with an undiagnosed pleural effusion is PA. Dyspnea is the most common symptom. The pleural fluid is almost always an exudate. Diagnosis is established by spiral CT scan or pulmonary arteriography. Treatment of a patient with a pleural effusion secondary to PE is the same as for any patient with pulmonary embolism. Tuberculous pleuritis. In many parts of the world, the most common cause of an exudative pleural effusion is TB. TB pleural effusions are usually associated with primary TB and are thought to be primarily caused by a hypersensitivity reaction to tuberculous protein in the pleural space. Patients with tuberculous pleuritis present with combinations of fever, weight loss, dyspnea, or pleuritic chest pain. The pleural fluid is an exudate with predominantly small lymphocytes. The diagnosis is established by demonstrating high levels of TB markers in the pleural fluid, adenosine deaminase ADA, less than 4T, interferon gamma more than 140, or positive PCR for tuberculous DNA. Alternatively, the diagnosis can be established by culture of the pleural fluid, needle biopsy of the pleura, or thoracoscopy. The recommended treatment of patients with pleural and pulmonary TB is identical. Effusion of secondary to viral infection. Pleural effusions are uncommon in patients with AIDS. The most common cause is Kaposi's sarcoma followed by parapneumonic effusion. Other common causes are TB, Cryptococcus, and primary effusion lymphoma. Pleural effusions are very common with pneumocystis carini infection. Helothorax occurs when the thoracic duct is disrupted and bile accumulates in this pleural space. The most common cause of helothorax is trauma, but it may also result from tumors in the mediastinum. Patients with helothorax present with dyspnea and a large pleural effusion is present on the chest radiograph. Thoracentesis reveals milky fluid and biochemical analysis reveals a triglyceride level that exceeds 1.2 millimole per liter. Patients with helothorax and no obvious trauma should have a lymphangiogram and a mediastinal CT scan to assess the mediastinum for lymph nodes. The treatment of choice for most helothoraces are insertion of a chest tube plus the administration of octreotide. Hemothorax should be obtained on the pleural fluid. when it reveals bloody pleural fluid. If the hematocrit is more than half of in the peripheral blood, the patient is considered to have a hemothorax. Most hemothoraxes are the rest of trauma. Other causes include rupture of a blood vessel or tumor. Most patients with hemothorax should be treated with tube thoracostomy, which allows continuous quantification of bleeding. If the bleeding emanates from a laceration of the pleura, a position of the two pleural surfaces is likely to stop the bleeding. If the pleural hemorrhage exceeds 200 milliliters per hour, consideration should be given to thoracoscopy or thoracotomy. Miscellaneous causes of pleural effusions are: if the pleural fluid amylase level is elevated, the diagnosis of esophageal rupture or pancreatic disease is likely. If the patient is febrile, has predominantly polymorph nuclear cells in the pleural fluid, and has no pulmonary parenchymal abnormalities and intra-abdominal abscess, should be considered. Ovarian tumors can produce ascites and a pleural effusion, Meigs syndrome. Several drugs can cause pleural effusion. The associated fluid is usually eosinophilic. Pleural effusions commonly occur after coronary artery bypass surgery. Other medical manipulations that induce pleural effusions include abdominal surgery, radiation therapy, liver, lung, or heart transplantation, and intravascular insertion of central lines. You see here differential diagnosis of pleural effusions, transudative pleural effusions. You see how many conditions can cause exudative pleuritis. Also, drug-induced pleural disease, nitrofluorination, dantrolene, methicillin, bromocriptine, procarbazine, amiodarone, and so on. And now about pneumothorax. Pneumothorax is the presence of gases in the pleural space. Is one that occurs without antecedent trauma to the thorax, a spontaneous pneumothorax. Whereas a primary spontaneous pneumothorax occurs in the absence of underlying lung diseases, a secondary pneumothorax occurs in its presence. A traumatic pneumothorax results from penetrating or non-penetrating chest injuries. A tension pneumothorax is a pneumothorax in which the pressure in the pleural space is positive throughout the respiratory cycle. Chest X-ray shows white visceral pleural line and absence of vessel marking peripheral to lung. You see here large right pneumothorax with near complete collapse of the right lung. Also note that the patient has subcutaneous emphysema, yellow arrow. You see here pneumothorax on left side. We have here left side pneumothorax, also fluid in the pleural space. Hydropneumothorax. It's called hydropneumothorax. CT scan of large right side pneumothorax. Note the significant collapse of the right lung with adhesion to the anterior chest wall. Pleural reflection is highlighted with red arrows. The patient has severe underlying emphysema. Here you see also pneumothorax, left-sided pneumothorax. Primary spontaneous pneumothoraces are usually caused by a rupture of apical pleural blebs, small cystic spaces that lie within or immediately under the visceral pleura. Primary spontaneous pneumothoraces occur almost exclusively in smokers. The initial recommended treatment for primary spontaneous pneumothorax is simple aspiration. If the lung does not expand with aspiration, or if the patient has a recurrent pneumothorax, thoracoscopy with stapling of blebs and pleural abrasion is indicated. Thoracoscopy or thoracotomy with pleural abrasion is almost 100% successful in preventing recurrence. Secondary pneumothorax are caused by chronic obstructive pulmonary disease, COPD, but pneumothoraces have been reported with virtually every lung disease. Nearly all patients with secondary pneumothorax should be treated with tube thoracostomy. Most of them should also be treated with thoracoscopy or thoracotomy with the stapling of blebs and pleural abrasion. If the patient is not a good operative candidate or refuses surgery, then pleurodesy should be attempted by the interpleural injection of a sclerosing agent such as doxycycline. Traumatic pneumothorax can result from both penetrating and non-penetrating chest trauma. Traumatic pneumothoraxes should be treated with tube thoracostomy unless they are very small. If a hemopneumothorax is present, one chest tube should be placed in the superior part of the hemithorax to evacuate the air, and another should be placed in the inferior part of the hemithorax to remove the blood. Traumatic pneumothorax, iatrogenic pneumothorax is a type of traumatic pneumothorax that is becoming more common. The leading cause are transthoracic needle aspiration, thoracentesis, and the insertion of central intravenous catheters. Most can be managed with supplemental oxygen or aspiration, but if these are unsuccessful, a tube tracheostomy should be performed. Tension pneumothorax, the positive pleural pressure is life-threatening both because ventilation is severely compromised and because the positive pressure is transmitted to the mediastinum, which results in decreased venous return to the heart and reduced cardiac output. The diagnosis is made by physical examination showing an enlarged hemithorax with no breath sounds, hypersonance to percussion, sheath to the mediastinum to the contralateral side. Tension pneumothorax must be treated as a medical emergency. If the tension in the pleural space is not relieved, the patient is likely to die from inadequate cardiac output or marked hypoxemia. A large bore needle should be inserted into the pleural space through the second anterior intercostal space. If large amounts of gas escape from the needle after insertion, the diagnosis is confirmed. The needle should be left in place until a thoracostomy tube can be inserted. The mediastinum is the region between the pleural spaces. Now we discuss the disorders of the mediastinum. It's separated into three compartments. The anterior mediastinum extends from the sternum anteriorly to the pericardium and brachiocephalic vessels posteriorly. It contains the thymus gland, the anterior mediastinal lymph nodes, and the internal mammary arteries and veins. The middle mediastinum lies between the anterior and posterior mediastina and contains the heart, the ascending and transverse arches of the aorta, the vena cava, the brachiocephalic arteries and veins, the phrenic nerves, the trachea, main bronchi and their contiguous lymph nodes, and the pulmonary arteries and veins. The posterior mediastinum is bounded by the pericardium and trachea anteriorly and the vertebral column posteriorly. It contains the descending thoracic aorta, esophagus, thoracic duct, azygos and hemiazygos veins, and the posterior group of mediastinal lymph nodes. Mediastinal masses. The first step in evaluating a mediastinal masses is to place it in one of three mediastinal compartments because each has been different characteristic lesions. The most common lesions in the anterior mediastinum are lymphomas, thymomas, teratomatous neoplasms, and thyroid masses. The most common mass in the middle mediastinum are vascular masses, lymph node enlargement from metastasis, or granulomatous disease and pleuroepicardial and bronchogenic cysts. In the posterior mediastinum, neurogenic tumors, meningocells, meningomyelocele, gastroenteric cysts, and esophageal diverticula are commonly found. CT scanning is the most valuable imaging technique for evaluating mediastinal masses. Barium studies of the gastrointestinal tracts are indicated in many patients with posterior mediastinal lesions because hernials, diverticula, and achalasia are readily diagnosed in this manner. A definite diagnosis can be obtained with mediastinoscopy or anterior mediastinotomy. In many patients with masses in the anterior or middle mediastinal compartments, alternative ways to establish the diagnosis are video-assisted thoracoscopy, VATS, thoracoscopy, mediastinoscopy, or mediastinotomy. In many cases, the diagnosis can be established and the mediastinal mass removed with video-assisted thoracoscopy. Acute mediastinitis either are caused by esophageal perforation or occur after median sternotomy for cardiac surgery. The esophageal rupture can occur spontaneously or as a complication of esophagoscopy or insertion of a Blackmore tube. The incidence of mediastinitis after median sternotomy is 0.4 to 5%. Patients most commonly present with wound drainage. Other presentations include sepsis or a widened mediastinum. The diagnosis is usually established with mediastinal needle aspiration. Treatment includes immediate drainage, debridement, and parenteral antibiotic therapy, but the mortality rate still exceeds 20%. The spectrum of chronic mediastinitis ranges from granulomatous inflammation of the lymph nodes in the mediastinum to fibrosing mediastinitis. Most cases are caused by TB or histoplasmosis, but sarcoidosis, silicosis, and other fungal diseases are at times causative. Patients with granulomatous mediastinitis are usually asymptomatic. Patients with fibrosing mediastinitis usually have signs of compression of some mediastinal structures, such as the superior vena cava or large airways, phrenic or recurrent laryngeal nerve paralysis, or obstruction of the pulmonary artery or proximal pulmonary veins. Other than antituberculous therapy for tuberculous mediastinitis, no medical or surgical therapy has been demonstrated to be effective for mediastinal fibrosis. Pneumomediastinum. In this condition, there is gas in the interstices of the mediastinum. The three main causes are: first, alveolar rupture with dissection of air into the mediastinum; second, perforation of or rupture of the esophagus, trachea, or main bronchi; and third, dissection of air from the neck of the abdomen into the mediastinum. Typical of the patients has severe substernal chest pain with or without radiation into the neck and arms. The physical examination usually reveals subcutaneous emphysema in the suprasternal notch and Hamas size, which is crunching or clicking noise synchronous with the heartbeat and best heard in the left lateral decubitus position. And final slide of disorders of the mediastinum is diagnosis is confirmed with the chest radiograph. Usually no treatment is required, but the mediastinal air will be absorbed faster if the patient inspires high concentrations of oxygen. If mediastinal structures are compressed, The compression can be relieved with needle aspiration. Thank you for your attention.